Hello friends, I am Dr. Surya Prakash. I am here with a new topic, surgical topic, which is very important from the point of view of exams as well as all practical purposes. Today we will be discussing about the ulcer. In this topic, our learning objectives will be mainly focusing on definition, etiology, classification, pathophysiology, clinical presentation, workup, and lastly, we will be focusing on the treatment aspect of the ulcer as well. So let's first start with the definition. Ulcer can be defined as a break in the continuity of the skin or the mucous membrane. It's basically the breach in the continuity of skin or the mucous membrane. It may either follow molecular death of the surface epithelium or its traumatic removal. By this slide, I am trying to show you the parts of ulcer, which basically comprises of margin, edge, floor and base. It's very sometimes confusing. I will try to clarify it. Margin is the junction between normal epithelium and ulcer. Edge is the area between margin and the floor of ulcer. Floor is the exposed surface of the ulcer and base is the part on which the ulcer rests. You have to keep these in mind because it's sometimes very confusing. Now, as we have discussed about the parts of ulcer, on the basis of types of edges, the ulcer is mainly divided into four types. Punched out, which can be seen in trophic ulcers and arterial ulcer. Then comes the undermined edge, which can be seen in pressure type of sores, for example, bed sores. Then the third one is the everted type of edge, which can be seen in squamous cell carcinomas. And rolled type of edge can be seen in basal cell carcinoma. This is very important from the point of view of examination. You have to mug it up, and as I have shown the diagram over here, then it becomes easy. Now let's discuss about the etiology, which can include traumatic causes, vascular insufficiency and neoplastic conditions. Traumatic causes will include mechanical, physical and chemical. Then vascular insufficiency will include arterial and venous. Then comes the neoplastic condition, which will include squamous cell carcinoma, basal cell carcinoma, Kaposi's sarcoma, and last will be the malignant melanoma. Again, continuing with the etiology, metabolic diseases will include diabetes mellitus. Malnutrition can also be a cause of this ulcer, which will be including beriberi due to vitamin B deficiency, tropical ulcer. Inflammatory processes can also cause this, which will include cellulitis. Infective processes will include tuberculosis, syphilis, and many fungal infections can also be the cause of ulcer. Other causes can be neurogenic, like bedsore, perforating ulcers, because of the cord lesions, and peripheral neuropathies like syphilis and diabetes mellitus. Then last other causes will be also including like Basin ulcer and Martorell's ulcer, which is also called hypertensive ulcer. Now, one classification can also be done on the basis of etiology, clinical classification, and pathological classification. We will be discussing this in detail. Now, first, etiological classification. This will include traumatic ulcers, vascular ulcers, neoplastic ulcers, metabolic ulcers, ulcers due to malnutrition, inflammatory ulcers, infective ulcers, and miscellaneous type of ulcers. These all will come under the etiological classification. Now the clinical classification. It includes mainly three type of ulcers: spreading ulcer, healing ulcer, and callous ulcer. We will be discussing each one of them. First is spreading ulcer. The surrounding skin of the spreading ulcer is inflamed. Floor will be covered by slough and there will be no evidence of granulation tissue and purulent discharge will be there. I will show few diagrams which will help you to understand it better. In this picture you can see a ulcer which is covered with yellowish necrotic material which is called slough, and you can see the exudate which is discharge coming out of the ulcer. In this picture you can see the inflammation of the scrotal skin with pus discharge which is also called purulent discharge. You can evidently see the signs of inflammation in the scrotal skin. In the next slide I will be discussing about the inflammatory signs, which mainly includes calor, which means heat, rubor, which means redness, tumor is swelling, dolor means pain, and functional loss means loss of function. So these are the signs of inflammation which is seen in any case of inflammation. You should always look for the signs of inflammation. These are the very basic thing, but it helps to get to the diagnosis. Now coming to the healing ulcer. In this type of ulcer, the surrounding skin is not inflamed. Floor is mainly covered with the granulation tissue. Edge shows the bluish outline of the growing epithelium, and there will be slight serous discharge. This is picture of healthy, or you can say healing ulcer. You can see over here healthy granulation tissue. The surrounding epithelium is bluish, which is now healing phase. The surrounding skin is also not inflamed and slight serous discharge is seen over here. Now coming to callous ulcer. It has pale granulation tissue in the floor. Considerable amount of induration will be there at the base, edge and the surrounding skin, and there is no tendency towards healing. Now coming to pathological classification. This will include non-specific ulcers, specific ulcers, as well as malignant ulcers. Now non-specific ulcers will include traumatic ulcers, which will so obviously caused by trauma, arterial ulcers, which will be caused by ischemia, for example gangrenous ulcer. Venous ulcer will include varicose ulcer. Neurogenic ulcer will be trophic type. Ulcers associated with malnutrition. Ulcers associated with other diseases like anemia, avitaminosis, gout and rheumatoid arthritis. Then miscellaneous type of ulcers will also be included in this type of non-specific ulcers. Now there will be few specific ulcers which will be seen in particular conditions always. Yeah, it is more specific for particular type of conditions like infective ulcers, which can be seen in diseases like syphilis, tuberculous ulcers, fungal ulcers, Buruli ulcers, I have included few pictures also for the better understanding of you all. This is the syphilitic ulcer on the penis. This is a tubercular ulcer which is seen over the chest wall. This is Buruli type of ulcer which is caused by Mycobacterium ulcerans. Now coming to malignant ulcers, this will include squamous cell carcinoma, basal cell carcinoma which is also called rodent ulcer, malignant melanoma, ulcerating adenocarcinoma, etc. Now what is the pathophysiology? Any kind of ulcer has three phases: extension phase, transition phase and repair phase. तो सबसे पहले extension phase. The floor will be covered with exudate and slough. I have already shown the picture how a slough looks. The base is indurated. Indurated means there will be feeling of hardening. The discharge is purulent or even blood stained. Then comes the transition phase, which is the phase when the ulcer has started preparing itself for the healing. The floor becomes cleaner and the slough part separates. The induration of the base decreases, or you can say diminishes. The discharge becomes more serous and there will be small reddish area of granulation tissue on the floor. Then third and last phase will be there, which will be repair phase. In this, transformation of the granulation to fibrous tissue occurs, which ultimately result to the contraction of the wound, which forms the scar. The epithelium gradually extends from the new edge to cover the floor, and the rate at which it contracts, or you can say uh, covers, is 1 mm per day. And the healing edge consists of three zones: outer zone, middle zone and inner zone, and all has the different characteristic as I have mentioned in the slide. Now we will be discussing about the clinical presentation, how the patient with ulcer will present to us. It will include two parts: history as well as physical examination. Now the history part. इसमें जो हमें चीज़ पूछनी होती है that is duration, कि how long the ulcer has presented. It can be of acute type and chronic type. Or second thing will be the mode of onset. How has the ulcer developed? It can be following trauma, spontaneous, like ulceration of a lymph node in tuberculous, और बर्न्स के केसेस में माजोरिन अल्सर जो होते हैं. ना हिस्ट्री में जो और बात हमें पूछनी होती है वो होता है पेन. Whether the ulcer is painful or painless or slightly painful. Painful ulcers will be mostly associated with inflammation, and we have already discussed about the signs of inflammation. Then there can be slight painful ulcers, which will include the tuberculous type. Then painless ulcers will include specific ulcers like syphilitic ulcer, neurogenic ulcers and malignant ulcers. Next thing will be the discharge, whether the ulcer is having any type of discharge. That can be pus, bloody or serous discharge. Next important thing you will be asking about any associated disease which may lead to ulcer, like tuberculosis, syphilis, diabetes mellitus or any kind of nervous diseases. Then ये सारी बातों को जानने के बाद then comes the physical examination, which will include the general examination, local examination as well as systemic examination. This all three will be included. Then starting with the general examination, इसमें वो सारी बातें include होंगी, whether the patient is anemic, whether he is icteric, pallor है, clubbing है, icterus है, cyanosis है. These all the general examinations will be included in this part. Then coming to local examination, which will include inspection, palpation, examination of the lymph node, and examination for any kind of vascular insufficiency, which may also lead to ulceration or ulcer formation. Now coming to inspection, site, it gives clue about the diagnosis. Like very typical ये जो होते हैं varicose ulcers will be typically on the lower limb near the medial malleolus. Rodent ulcer will be over the face. Tuberculous ulcer will be involving the cervical area. Tropical ulcers will be seen over the heel, and malignant ulcer can be seen anywhere. Now on inspection, you have to first see the shape of the ulcer, because there are typical shape which can be seen in different specific type of ulcers. Like tuberculous ulcers will be oval in shape, syphilitic ulcer will be circular in shape, varicose will be vertically oval in shape, and malignant will be irregular in shape. Size is also important because it will give you an idea about the timing of ulcer, or you can say duration of ulcer. Smaller the ulcer, the shorter time it will take to heal. It also gives us an idea about the duration to heal. Next thing which you should see in inspection will be the surrounding skin, whether it is red or edematous, which will be indicating acute inflammation. About the floor and surface, uh, how is the granulation over the floor? If it is red, then it indicates it is healing type of ulcer, and black floor will be seen in ulcers like malignant melanoma. Number is also a good indicator for knowing which type of ulcer is this, like tuberculous ulcer, gummatous ulcer, varicose ulcer. In this kind of ulcer, the number will be more than 1. Then discharge. The character of discharge should also be noted, such as in healing ulcer, scanty amount of serous discharge will be there. Spreading ulcers, purulent discharge will be there. Tuberculous ulcers, serosanguinous discharge will be there. In malignant ulcers, bloody discharge can be there. And whole limb should be examined. In cases of ulcer, like in varicose vein, lower limb should be examined. About the tenderness, I think I have already included in the previous slides. Tender, acutely inflamed ulcer will be tender. Slightly tuberculous ulcers or syphilitic ulcers will be slightly tender, and malignant or chronic ulcer or neurogenic ulcers will be non-tender. Edge and surrounding skin, hard indurated surrounding will be of malignant ulcer, and firm induration will be of chronic or syphilitic ulcer. Now in palpation, base, it is the area over the which ulcer rests. If there will be slight induration, it will be syphilitic type of ulcer. Marked induration will be seen in cases of malignant ulcer. Depth should all be examined. For example, trophic ulcers may be so deep that it reaches the bone. Bleeding is a very particular, or you can say typical sign of malignant ulcer. And fixity to the deeper structures is also a sign of malignant ulcer. Examination of lymph node should always be done, because it is missed by many students, which is very important. Nearby lymph node should always be examined. Or in few cases like stomach cancer, left supraclavicular lymph node will be involved. It should be kept in mind. Examination for vascular insufficiency must be done. Now coming to workup, which will include laboratory, imaging and histopathology. Laboratory investigations will mainly include hematological, which will include full blood picture and erythrocyte sedimentation rate, hemoglobin levels, Microbiological will include gram staining for tuberculous, ruling out tuberculous origin, culture and sensitivity of the pus, and biochemical examination for the glucose level to know whether the patient is diabetic or not. It gives a rough idea whether the healing of the ulcer will take very long duration or not, and whether the blood glucose level of the patient is controlled or not. Then radiological investigations, or you can say imaging, may include chest x-ray, x-ray of the affected limb, Doppler ultrasound, CT scan, and MRI. Histopathology is particularly important to confirm the diagnosis, whether the ulcer is malignant or tubercular or syphilitic in origin. Now coming to treatment, it depends basically on the cause. You have to manage it conservatively, or there can be surgical treatment needed for the management of the ulcer. Conservative treatment will include dressings, uh, treating the infections which can be bacterial, fungal, syphilitic or tubercular, steroids, trace elements, application of topical antimicrobial agents, nutritional support, limb elevation, controlling of blood sugar, hyperbaric oxygen therapy, and compression bandage. I have discussed it in point wise manner, but every point in itself is descriptive. I will make detailed videos in coming time individually. Now, surgical treatment will be including debridement, which means desloughing, or you can say cleaning the dead tissue. Sloughectomy is the removal of the slough. Then once the wound becomes healthy, then skin grafting or flaps can be done. If it is non-salvageable, then amputation should also be thought of. Now, talking about the complications which an ulcer can lead, it may lead to chronic osteomyelitis. If the ulcer reaches to the bone, it can lead to malignant changes. Septicemia can also occur because of that. Limb amputation has to be carried out if it is not controlled, and it can also lead to septic emboli. I, Dr. Surya Prakash, like to thank you all for watching this video. Please like, share, and subscribe if you like it. I will be making and discussing on different surgical topics in the coming days, and I welcome wholeheartedly your suggestions and queries. Thanks a lot once again.